Welcome to Part 3, Non-Invasive Mechanical Ventilation of Dr. Manny's YouTube Learn-shops. The objectives for this session are to review non-invasive mechanical ventilation, looking at the history, negative pressure and positive pressure non-invasive ventilation, the indications for its implementation, the selection criteria and contraindications, certain interfaces of delivery and modes of delivery, the advantages and disadvantages of them, and the predictive factors for success when using non-invasive positive pressure ventilation. And we'll look at who actually is allowed or authorised or accredited to provide non-invasive positive pressure mechanical ventilation. Defining NIV, or non-invasive mechanical ventilation, it's the use of a breathing support which administers gas, air, oxygen through a face mask or a nasal mask. NIV uses techniques that don't require an artificial airway, such as a tracheal tube. The air, usually with oxygen added, is given through a prong, a mask, and it's delivered using a positive pressure. And generally the amount of pressure is alternated depending on whether someone is breathing in, inspiration, or needs support, or breathing out, expiration, also needing support. It's an example of a face mask, of non-invasive positive pressure ventilation. Let's briefly review the history of NIV, non-invasive ventilation. In 1876, the concept of the first iron lung was initiated by Wallonez. That's a diagram of it that you can see. In 1889, Alexander Graham Bell, an inventor in the United States of America, supported a newborn infant using his prototype of the iron lung. In 1928, Drinker introduced his version of the iron lung and maintained an 8-year-old girl with poliomyelitis for approximately 122 hours. During the polio epidemic in Boston, in the United States of America, during the 1940s, negative pressure ventilation was initiated on a grand scale. During the 1960s, positive pressure ventilation was preferred. And during the 1990s, there was a revival of an interest in non-invasive mechanical ventilation. Looking at our time scale, essentially you've got 4 stages: ancient history, Middle Ages, Renaissance, and the modern era for non-invasive mechanical ventilation. And it was during the period from 1990 essentially that there was a resurgence in the interest in non-invasive mechanical ventilation. Let's look at some of the techniques of the application. You've got non-invasive negative pressure ventilation, NIV, and you've got non-invasive positive pressure ventilation, NPPV. These are examples of non-invasive negative pressure ventilation, the iron lung. Here's an example of non-invasive positive pressure ventilation, where this is a survivor from the poliomyelitis epidemic, and instead of being in her iron lung constantly, she has the ability to come out of her lung and use intermittent positive pressure ventilation intermittently. Here, the application can also be employed to deliver nebulized medications. This one's using a Bird Mark 7 to intermittently deliver medication to the patient. Maybe she's an asthmatic. She triggers the device with her spontaneous breathing. Looking at non-invasive negative pressure ventilation, it can be used for a variety of different patients, whether it's now infants, children, or adults. Some of the devices these days are very non-invasive, just encompassing the thorax and creating a negative pressure. So how does NIVNPV work? Non-invasive ventilation. How does it work? Well, non-invasive ventilation negative pressure generators create a sub-atmospheric pressure, and this is created around the chest wall and promotes inspiration. By promoting inspiration using a negative pressure, gas just flows from an atmospheric pressure that is high to a pressure that is low intrathoracically or intrapulmonary. At the end of inspiration, which is determined by the machine, expiration occurs, which is passive. And this occurs by normal recoil of the lung, relaxation of the diaphragm, and the chest wall moving back into its pre-inspiratory position. So let's look at non-invasive positive pressure ventilation. This is also referred to as intermittent positive pressure breathing. And this is short-term breathing. It's a mode that now is pressure cycled, and it's typically patient triggered. And it's used to treat atelectasis, or the delivery of aerosol medications. How does it work? Non-invasive ventilated positive pressure ventilation. Well, NIV positive pressure ventilators create a supra-atmospheric pressure inside the airways during inspiration, so that it essentially forces gas to go into the airways. At the end of inspiration, expiration occurs passively, with normal lung recoil, returning of the diaphragm back to its pre-inspiratory position, and the thorax also returning back to its pre-inspiratory position. So when do we use NIV, non-invasive ventilation? Well, the indications are primarily for acute respiratory failure, but essentially the patient does have to be stable. So this can be used for acute exacerbation of chronic obstructive pulmonary disease, forms of chronic respiratory failure, community-acquired pneumonias, cystic fibrosis, acute asthma, post-extubation, or patients that have weaning difficulties. It can be for obese patients with hyperventilation syndrome, or it can be for post-operative patients. It can be for patients that have got thoracic wall anomalies, such as kyphosis or scoliosis or kyphoscoliosis, and patients who are not a candidate for invasive intubation. It can also be used for patients with heart problems, such as cardiogenic acute pulmonary edema, or in the early stages of acute respiratory distress syndrome. And patients that are immunocompromised, that are at risk of developing a chest infection because of invasive tracheal tubes. What then is the selection criteria? Well, according to most intensivists, there have to be at least 2 of the following. They've got to have a respiratory rate of greater than 25 breaths per minute, respiratory distress with dyspnea, use of accessory muscles, abdominal paradoxical breathing, and laboratory results such as arterial blood gases that demonstrate a respiratory acidosis, or a PaO2-FiO2 ratio that's less than 200 millimeters of mercury. What then are the contraindications? And there are 2 types, absolute and relative. Absolute contraindications basically are as follows. The patient says no, they refuse, they don't give consent. The patient is uncooperative because non-invasive mechanical ventilation using a face mask or prongs requires the patient's cooperation. Severe agitation, an impaired level of consciousness, periods of apnea. They can't protect their airway because reflexes such as cough, gag and swallow may not be present. Uncontrolled vomiting, hemoptysis or hematemesis, copious secretions. The patient may have had facial trauma or facial surgery, gastric surgery, an unstable cardiopulmonary status, respiratory arrest or cardiac arrest. Essentially, the patient has to be cooperative and stable. Relative contraindications are in relation to other aspects of the patient's condition and probably in relation to whether the physician believes that the patient is a candidate. And these relative contraindications could include extreme anxiety, an uncooperative patient who can be calmed, a mild decreased level of consciousness, copious secretions, morbid obesity, pregnancy, previous failure with non-invasive mechanical ventilation, progressive respiratory failure, suspected acute coronary syndrome such as STEMI or non-STEMI, possible hemodynamic instability, and life-threatening dysrhythmias such as ventricular tachycardia, ventricular fibrillation, premature ventricular complexes, atrial fibrillation, etc. But that will be a decision that will be made by the treating physician. What are some of the interfaces that can be employed for non-invasive ventilation delivery? The most common are orofacial masks or nasal masks. Others could include mouthpieces, nasal pillows, total face masks, helmet devices which encompass the entire head. I mean, this comes down to economics and it comes to patient preferences. There's an example of an orofacial nasal mask. There's an example of a nasal pillow. Also can be referred to as a nasal mask. Then you've got interface issues. Nasal masks require compliance. And these are typically used for nasal breathers because they're less claustrophobic. One of the benefits is that the patient can eat and drink, but as soon as they open their mouth, remember, they will break the seal and gas will escape through the mouth. And if required to, they can expectorate. Facial masks are essentially for mouth breathers. Facial masks could promote eye irritation. There is a risk of pressure ulcer development, gastric distension with gas going into the gastrointestinal tract, and they could be considered claustrophobic. And as a consequence of the seal, there are nutritional issues that may be involved. They can't eat and drink. What are some of the modes of delivery? Well, they can be delivered using a volume-controlled ventilator, a pressure-controlled ventilator, continuous positive airway pressure, CPAP, or bi-level positive airway pressure, BIPAP. Volume-cycled modes are essentially ventilators that deliver a set tidal volume with each mechanical breath. For example, if a patient weighs 70 kilograms, then the formula for the tidal volume will typically be 5 to 7 mils per kg. We'll use the 5 mils per kg. So 70 by 5 equals 350 mils. That would be how much gas would be delivered during each volume cycled breath. Then you've got pressure cycled Pressure cycle ventilators deliver a set pressure for each mechanical breath. So for example, the doctor could set a pressure of 10 centimetres of water, and the pressure that's set when it's delivered, inspiration will be terminated. However, with pressure cycle ventilation, the tidal volume is not guaranteed. It's unique, it's individual with each individual patient, depending on what their problem is and what their airway and lung compliance is. CPAP, continuous positive airway pressure, as a mode, it's not considered to be a true ventilation mode, rather an adjunct. And this is for people who are able to breathe spontaneously. It doesn't actively assist inspiration, but it's an applied continuous airway pressure which keeps airways open. And typically, the range that is set is between 5 and 12 centimetres of water. The benefits are it will increase oxygen delivery, or the arterial content in blood, the PaO2. It increases the functional residual capacity, the FRC, which is the amount of air that remains within the lung during expiration, and as a consequence, it decreases the work of breathing. Work of breathing is seen in the use of accessory muscles. Therefore, it's used for atelectasis, pulmonary edema, and commonly sleep apnea. What then are some of the indications for continuous positive airway pressure? Traditionally, it would be used for sleep apnea, which is demonstrated by obstruction, which you can hear because they snore. It can also be used for respiratory distress or failure with patients who are still reasonably stable. And this is determined by their vital signs, such as tachypnea, greater than 40% of the normal rate, nasal flaring, grunting and chest retractions, which are typically demonstrated in paediatric patients, and cyanosis. The arterial blood gas analysis, their PaO2 is typically less than 50 millimetres of mercury on fairly high FiO2s greater than 0.6. It can also be employed for conditions that decrease FRC, the functional residual capacity, as a consequence of an increase in dead space, such as pneumonia, atelectasis, pulmonary edema, after thoracic surgery, in infants with meconium aspiration and increased mucus states, which occur in a number of chronic obstructive pulmonary disorders, such as cystic fibrosis, for example, or bronchiectasis. Here's an example of a nasal pillow. A nasal mask. Let's look at BIPAP, or a bi-level mode. Bi-level positive airway pressure is a breathing mode that's used to treat sleep apnea as well, and some lung conditions. The difference from CPAP to BIPAP is that there are two pressure settings. The higher pressure setting is for inhalation or inspiration, and this is IPAP, inspiratory positive airway pressure. And typically it's set at a higher rate than the second setting. An example would be between 6 and 12 centimetres of water, and primarily it's to open the airway and let the air go in effectively. And this is during inspiration. The lower airway pressure during exhalation is called EPAP, expiratory positive airway pressure. And typically it's set at a lower pressure between 3 and 5 centimetres of water, because again we still have passive recoil of the lungs, we still have passive recoil of the diaphragm, and we still have passive recoil of the thorax during expiration. And this is primarily to assist the air to escape during exhalation to ensure that CO2 is removed and that there isn't any air trapping. Here's an example of normal breathing. And normal breathing typically during inspiration is negative and during expiration is positive. CPAP elevates the breathing pressures so that it becomes positive. It's a continuous positive airway pressure to maintain the airways are open. Then you've got BIPAP, bi-level positive airway pressure. You've got inspiration, which is inspiratory positive airway pressure, and you've got expiration, which is expiratory positive airway pressure. But they are both positive airway pressures. If we compare CPAP, continuous positive airway pressure, to BIPAP, bi-level positive airway pressure, let's review. CPAP is typically inexpensive. It's simple to use, it doesn't require much monitoring, and it provides a continuous positive pressure during inspiration and expiration, but the pressures are the same. This is something that can be used out in the field, home use, use in the community, for people who have apnea problems, or possibly here chronic problems that require support. BIPAP, on the other hand, bi-level positive airway pressure, is more expensive. It's a more complex machine. And it needs constant monitoring. It also provides continuous positive airway pressure, but two types. Inspiratory positive airway pressure, which is typically higher than the expiratory positive airway pressure, which is typically lower. And this is typically used in hospitals. However, it is coming out more so into the community. Both machines, CPAP and BIPAP, are becoming more user-friendly. What are the advantages of non-invasive mechanical ventilation? Well, the advantages are that it's simple to use for healthcare providers like nurses who are not intensive care nurses. They could be community healthcare nurses. It's also advantageous to support early respiratory problems, correct hypoxemia that doesn't have hypercarbia issues. Ventilation can be employed outside the hospital, as I said. Patients can eat and drink, depending on the device that they're using, of course. And it's good for patient comfort. There typically doesn't require any sedation, or if it does, reduced. And you avoid complications which are associated with tracheal tubes. The application is simpler and removal is simpler. What then are some of the disadvantages associated with non-invasive mechanical ventilation? Well, the masks may be uncomfortable. If you're a person who suffers from claustrophobia, the masks may initiate that. There could be facial pressure and necrosis issues. Because the airway is not protected, there may be an element of risk associated with gastric content aspiration. Suctioning of the trachea is not available. There could be gastric distension, as indicated in the chest X-ray, the chest and abdominal X-ray that you can see on the screen, with a huge gas bubble. It may require a nasogastric tube to keep the stomach decompressed. Nutrition may be an issue because they've got a face mask. And if you've got non-compliance or problems with seals, there can be gas leaks. Because of the mask, if a mask is employed, there could be eye irritations And there could be ventilator and patient asynchrony. What then are some of the factors that indicate you'll be successful if you use non-invasive mechanical ventilation? Well, young patients seem to have better success rates than older patients. You need cooperative patients, otherwise it won't be as effective. There has to be an ability to coordinate breathing with ventilation, which means no bucking or fighting the ventilator or the mask. Cooperation again. If you're really, really sick, unstable, it probably isn't going to be as beneficial as if you are stable and the degree of illness or lung problem or cardiac problem isn't as severe. If now the acid-based arrangements, meaning pH, PaCO2, aren't as severe, then it's probably going to be an indicator for success. And clinically, if there's an improvement in your condition, it probably is going to be more beneficial than if you're really ill and unstable, as we indicated earlier. Who then is allowed to give non-invasive positive pressure mechanical ventilation? Well, depending on which country you're in, you have respiratory therapists. Doctors, nurses, paramedics, patients and family, but really it depends on education, training and experience. It's all very well to say, well, a doctor can provide or authorise, but if they don't know how to use the device or the indications or the contraindications, then that could be problematic. And the same applies to nurses, paramedics, patients and their families. So really, who can provide it? Well, it depends on training and experience, resource availability, monitoring capabilities, and managing any potential complications. Common sense. So the take-home message, again, is healthcare providers must ensure that when you're using something as scientific as mechanical ventilation, whether it's non-invasive or invasive, you should always care about what you do. The caring must always be in the science. Thanks. This is the end of part 3. Check out part 4 and any other Dr. Manny YouTube Learn shops if you're interested in what you've seen and heard. Thanks.